Good morning, everyone. It's my pleasure to welcome all of you for the Ceylon College of Physicians Speciality Update for month of October. This month, we have the collaboration of Sri Lanka Association for Geriatric Medicine to talk on several topics in geriatric medicine. I would like to welcome all of you who are joining us physically as well as virtually, and would like to welcome all resource persons from Sri Lanka as well as from UK. To introduce the first speaker, I would like to invite Dr. Barna Milavatana, the President, Sri Lanka Association for Geriatric Medicine. Over to you, Barna.
Good morning, and first of all, I would like to thank Ceylon College of Physicians for giving the valuable opportunity. The month of October is a month for geriatrics, that is starting from Elders Day, 1st of October. And we have arranged wide range of topics during this session. And so on behalf of Sri Lankan Association Geriatric Medicine, I would like to convey our sincere gratitude to Ceylon College of Physicians, as well as the speakers who contribute their knowledge and sharing their experience with us during this 2 hours time. So I would like to introduce the first speaker. And first speaker is Dr. Varsha de Soisa. Varsha is a senior lecturer in medicine at Faculty of Medicine, Ruhuna, and she is currently works as a consultant, honorary consultant physician with a special interest in geriatric medicine at Teaching Hospital, Karapitiya. Her talk for the day, titled as Sarcopenia, the Clinical Application. I would like to invite Varsha to deliver her speech.
Very good morning to all of you. Thank you, sir. Right. Sarcopenia is my talk for today. As you all know, sarcopenia is a progressive skeletal muscle disorder with adverse health outcome. Initially, this disorder is described only in elderly population. Although it is increasingly recognized in old age, it is not a disease confined to the older adult. During the next half an hour, I am going to talk about the prevalence and effect of sarcopenia on aging, screening and assessment, differential diagnosis, and I am going to go a little bit deeper on the non-pharmacological management of sarcopenia. Let's start with the case scenario. A 74-year-old man, retired teacher, admitted following a fall with head injury. But there was no loss of consciousness, urinary fecal incontinence or seizures associated with the fall. He described this incident as his legs were weak and they gave way while he was walking. He had many falls over the last 6 months, about 1 fall per month, but no loss of consciousness with any of these falls. He required support to stand up, following most of the falls. He felt tired and slept most of the time during the daytime and reluctant to go out and almost housebound. He had loss of appetite and lost about 4 kilograms over the last 6 months. He was on multiple medication, including medication for type 2 diabetes, hypertension, dyslipidemia, and benign prostatic hyperplasia. On examination, he was a thin-built man with a BMI of 19, pale, but no stigmata of other nutritional deficiency. His pulse rate is all right, 68 and regular, but there was a significant postural drop. With normal precordial examination and examination of his respiratory and abdomen were unremarkable. Neurological examination revealed a stocking type sensori loss, and there was wasting of his arm, thigh, and calf muscles. His hand grip strength was remarkably diminished. Joint examination revealed evidence of early osteoarthritic changes in bilateral knees, but preserved range of movements. So what are the probable causes of recurrent falls in this man? Is it polypharmacy, postural hypotension, or cardiac causes like arrhythmias? sensory motor neuropathy due to the advanced diabetes, osteoarthritis, frailty, sarcopenia. Let's get into our talk today. What is sarcopenia? So Rosenbeck defined sarcopenia in 1989 as loss of muscle mass. So it comes from a Greek word, like sarx means flesh, penia means loss. So loss of flesh or loss of muscle mass. About 2 decades later, so sarcopenia is defined as not only loss of muscle mass, but also loss of muscle strength and physical performance. Now this disorder is formally recognized as a muscle disease and it's been included in the International Classification of Diseases since 2016. I want you all to pay attention to this diagram. This is a mid-thigh CT scan of 2 women in their 72 years with the same BMI of 25. Oops. Right, okay. Yes, so the woman in the left hand side, the woman without sarcopenia, and the right hand side, is this working? All right, okay. Right. The woman in the left hand side is the woman without sarcopenia, and the right hand side is the woman with sarcopenia. So you can see the woman without sarcopenia has a good muscle mass with less fat mass around it. And the woman with sarcopenia has relatively low muscle mass with increased fat mass. What will happen to you when you are aging? You tend to have reduced lean body mass and increased fat mass if you don't take measures to keep maintain your the muscle mass. So this diagram further illustrates what will happen to your muscle mass with aging. It's the tale of 3 legs. So you can see the very muscular leg in the right hand, the left hand side. So this person can enjoy any kind of vigorous activities because he has a good volume of muscles like hiking, swimming, cycling without any problem. The one in the middle has relatively low muscle mass compared to the muscular leg, but still he can engage his activities of daily living without any problem, but he might have problem in engaging the vigorous activities. But compared to these 2 legs, one in the right hand has a very relatively very minimal muscle mass. So that person will have problem even attending to his activities of daily living. That is what will happen to your muscle mass with aging. So you will have a peak muscle mass by the age of 30, 35. After that, the muscle mass tend to decline at a rate of 8 to 10% per decade. Right? This will be further accelerate after the age of 70. Right. So moving from the muscle mass to muscle strength. So what will happen to the muscle strength with aging? These 2 diagrams illustrates what will happen to your muscle strength with aging. So one in the left is the muscle strength, how it's going to behave with aging for the males, and one for the right is for the female. So when you pay attention to the one for the male, you can see the muscle strength progressively increases up to the age of 30. Then it will plateau for another decade. So for maybe up to the age of 40, then it start declining. And this decline will be accelerates after the age of 60. So for the female, they start with a lower muscle strength, but the behavior is the same. So the muscle strength will be, they behave as same as for the male. The pattern is the same, but start with the lower muscle strength. Right. Sarcopenia. Is it a rare condition? No, it is a very common condition in the clinical practice, especially in the elderly. So it is estimated that 25% of the people over the age of 65 suffer from some kind of sarcopenia, and 60% of the elderly population over the age of 80 suffer from some kind of sarcopenia. So the prevalence varied between 10 to 27% in a meta-analysis conducted in 2022 with a mean age of 70 years. The highest prevalence was observed in Oceania and the lowest prevalence was observed in Europe. The global prevalence of severe sarcopenia range from 2% to 9%. What is our local situation? In Sri Lanka, prevalence of pre-sarcopenia, sarcopenia and severe sarcopenia among post-menopausal women was 4%, 3% and 1.2% respectively. The prevalence is higher in hospitalized older adults and the adults in nursing homes than community dwelling older adults. Right, sarcopenia is a vicious cycle. Why did I say so? When you are sarcopenic, you tend to have low muscle mass. So when you have low muscle mass, you will be easily fatigued when you engage in some kind of physical activity. So when you are fatigued, you tend to stop the physical activity prematurely, or you avoid any physical activity that gives you the fatigueness. So physical activity is the fuel for the muscle formation. No physical activity means there's no further lowering the muscle mass that in turn worsening the sarcopenia. So it is indeed a vicious cycle. Right, so there are two categories of sarcopenia. They are primary and secondary. So as I said earlier, the sarcopenia is an age-related condition. Right, that is called primary sarcopenia. But in some individuals, apart from aging process, we can identify other etiologies as a cause for sarcopenia. Like it could be activity related, like prolonged bed rest or sedentary lifestyle, or disease related, like advanced organ failure, inflammatory conditions, malignancy, endocrine diseases like androgen deficiency, growth hormone deficiency and so on, and nutrition related like malnutrition, malabsorption, GI disorders and so on. Right. So there's something called acute sarcopenia. So that is also very well described in elderly. So when an elderly person happens to be hospitalized for acute illness and he has to be on the hospital for more than 10 days, so that it is estimated that they can lose their muscle mass by 6 to 10% within 10 days. Compared to the young adult who has been hospital for even 1 month, they will lose around only 2%. So the acute sarcopenia is a condition that has lasted less than 6 months. Right, so it's the impact of sarcopenia. Sarcopenia means low strength, low muscle strength, low power, low muscular endurance. So that means easy fatigability, less exercise tolerance, risk of falls and fractures, and you will have problem with engaging in activities of daily living, your poor quality of life. Not only that, not only the problem with the mobility, they will have adverse, the cardiovascular problem, the adverse cardiovascular event, respiratory event, and the immunity will go down, the increased risk of infection, hospitalization, poor recovery from infection, and post-operative procedures, and this linked to the cognition, so they will have a problem with cognitive impairment, increased cognitive impairment, and overall they will have the poor quality of life, life expectancy, and the increased mortality. So this diagram further illustrates the consequences of muscle loss. So there have been many groups working on sarcopenia. I have listed few leading groups here. The European Working Group of Sarcopenia for Older People, International Working Group of Sarcopenia, and Asian Working Group of Sarcopenia. The guideline and definition established by European Working Group of Sarcopenia for Older People are being currently used worldwide due to the easiness of its application. So in 2010, European Working Group of Sarcopenia for Older People published a sarcopenia definition. So that was widely used since then, but about a decade later, this working group met again to fill the gap in the definition of sarcopenia based on the scientific evidence accumulated since then. So what did they do? They revised the guideline they made in 2010. What's the revision? What's the main revision? They identified muscle strength as the key predictor of adverse outcome, rather over the muscle mass. So the muscle strength comes to the forefront, right? And also they updated the algorithm for sarcopenia. So based on 2018 operational definition, they identified 3 categories of sarcopenia. As you all know, they are the probable sarcopenia, confirmed sarcopenia, and severe sarcopenia based on 3 criteria. What are they? Criterion 1, low muscle strength. Criterion 2, low muscle quantity or quality. Criterion 3, low physical performance. Right. So if you have only the evidence of low muscle strength, that means the probable sarcopenia. So diagnosis is confirmed if you have the evidence of low muscle strength and the low muscle quantity or quality. That means criterion 1 and 2. If criterion 1, 2 and 3 are all met, the sarcopenia is considered severe. Right. So they updated the algorithm. So based on the case finding, assessment, confirmation and severity determination. So the FACS model being formulated. So in a nutshell, this flow chart demonstrates the algorithm. They updated in 2018. So start with the case finding, you can see here. So if you suspect clinically the patient has sarcopenia and clinical suspicion, or else you can screen with using SARC-F questionnaire. So if it is positive, that means that person need further assessment to determine whether the patient has low muscle strength. So there are certain measures we have to take to determine the low muscle strength. If it is low, there are evidence of low muscle strength, that is, then the sarcopenia is probable. Then we have to subject the person to confirm whether the patient has sarcopenia. So then we have to assess the person's muscle quantity or quality with there are certain investigation for that. So if it is also confirmed the patient has low muscle mass, then that means he meet the criterion 2 as well. So sarcopenia is confirmed. Then person is subjected to assessment of whether the patient has evidence of poor physical performance to assess the severity with certain tests. So if it's confirmed the patient has poor physical performance, that he meets the criterion 3 as well, that confirm the severe sarcopenia. So it's coming with case finding, assessment, that confirm the possibility, that leads to the diagnosis as probable sarcopenia, confirmation for the sarcopenia is confirmed, then the severity assessment. So let's start with the case finding. In clinical practice, case finding will start when the patient complains of symptoms and signs of sarcopenia. What are they? So they will complain of recurrent falls, feeling fatigue, easy fatigability, slow walking speed, difficulty rising from chair, weight loss, unexplained weight loss, muscle wasting. So that means that the patient has some, the features, clinical features suggestive of sarcopenia. In that case, the person needs further assessment. Or else we can use the SARC-F questionnaire as a screening tool to screen the patient at risk of sarcopenia. So SARC-F has a low to moderate sensitivity and very high specificity to identify and predict the low muscle strength. Right. So this is the SARC-F questionnaire. You can see there are 5 domains to detect the strength: the walk-in, the transferring from chair or bed, climbing, and falls. The score equal or greater than 4 is predictive of sarcopenia with poor outcome. Right. So if the patient is positive for SARC-F screening tool is positive, or if the patient has symptoms and signs suggestive of sarcopenia, then that person need further assessment with a set of investigation or the test to confirm whether the patient has probable sarcopenia, the confirmed sarcopenia or severe sarcopenia. So these area of investigation the patient will subsequently subjected to. So we'll start with the assessment of muscle strength. So what are the things available to detect the low muscle strength? So we'll start with the hand grip strength determination. So low grip strength is a powerful predictor of poor patient outcome, like longer hospital stay, increased functional impairment, and so on. Because of its ease of use, the grip strength is advised for routine clinical practice. So how it is been assessed? Using a calibrated handheld dynamometer. When measurements on the hand grip is not possible, like a problem with the patient has a problem with hand, like the arthritic condition or a stroke. So then how can we measure the strength? Using the isometric torque methods can be used to measure the lower limb strength. And the other test is the chair stand test. To measure the muscle strength, the lower limb muscle strength, we measure the quadriceps strength. The patient is asked to rise from the standard chair 5 times, and without using his or her arms, and time taken for this is measured. Right, so moving from the muscle strength to the muscle mass or muscle quantity and quality determination. So this picture illustrates the DEXA scan, the DEXA scanner measuring the appendicular skeletal muscle mass. So DEXA scanner is widely used the clinical practice as a non-invasive method of measuring the skeletal muscle mass. So then there are other measures to, the other measures are available to measure the muscle mass. They are the anthropometric measures like, calf circumference, mid-arm circumference. However, these measures will also reflect the underlying nutritional status of the patient. So they are not very reliable measurements to measure the muscle mass. So moving from muscle strength to the muscle mass to the the measurement of physical performance. The physical performance has been defined as objectively measuring the whole body function related to the locomotion. So let's start with the gait speed test. So gait speed test considered as a quick, safe and reliable test for sarcopenia and is widely used in practice. So gait speed has been shown to predict adverse outcome related to sarcopenia. The commonly used gait speed test is the 4-meter the 4-meter usual walking test, and the speed measured to the patient is asked to walk on this 4-meter and the speed is measured. And the other thing is the time up and go test. The person is asked to rise from the standard chair and walk on a 3-meter, the target on 3 meter ahead, and turn around and come back and sit down. So time taken for this will be measured. These two tests is widely used as a measure of measuring the physical performance. There's something called a short physical performance battery, again measuring the physical performance, measuring the balance, gait speed and chair stand test. The maximum score is 12, and in any score 8 or less considered indicate the poor physical performance. So these 3 tests can be used to measure the physical performance. So this in this diagram shows you the sarcopenia diagnosis at a glance. Let's move to the differential diagnosis. What are the differential diagnoses of sarcopenia? They are mainly the cachexia and frailty. So, these are the main differences and similarity between sarcopenia and cachexia. So because of the interest of time, I'll skip this. And the frailty is the other differential diagnosis. This is the decline in bodily function in age, and it goes beyond the physical function to involve your mental and social function as well. So most frail patients have sarcopenia, but not all patients with sarcopenia are frail. Right, so there's something called sarcopenic obesity. What do you mean by sarcopenic obesity? So sarcopenia with excess weight and adiposity. So because of the patient has excess body fat as well as the patient has evidence of low muscle mass as well as the function. So it occurs when you consume a lot of calorie and at the same time no physical activity. So it poses a greater risk of health related outcome either more than the obesity alone or sarcopenia alone. So it has a greater risk of cardiovascular, the health outcome, adverse outcome, hypertension, diabetes and dyslipidemia. What's the treatment? Both diet induced weight loss and regular exercise. Moving to the management. So if you have identified the cause for the sarcopenia as a secondary cause, you have to treat, and the physical activity. The more research, the research has shown again and again physical activity as the cornerstone in the treatment of the sarcopenia, and diet, and the pharmacological management. More research is, evidence is needed to make any kind of solid recommendation for pharmacological management. Moving to the physical activity. So as I said, the physical activity is the cornerstone in the management, the treatment and prevention of sarcopenia. So there are 2 kinds of exercise. They are the aerobics and your resistant training. Though the aerobic exercise can increase the number of mitochondria in the skeletal muscle, they are the powerhouses in the skeletal muscle, but it's really the strength training that has been shown as the powerful intervention that help prevention and treatment of sarcopenia. So the goal is with the strength training is to progressively overload the muscle to increase the muscle fiber size, number and function, so that leads to improved strength, power and endurance over the time. So there are few good news. When you are engaging in strength training, that may preserve lean body mass even though you are following the low calorie diet to reduce body weight. If you just follow the low calorie diet without engaging in strength training, what will happen? Yes, you will lose your body fat and body weight, but at the same time you will lose your muscle mass as well. And the other news is that strength trained muscles have higher glucose uptake and lower insulin resistance and leading to better glycemic control. Right, this is the exercise prescription, resistant exercise prescription in summary. So I'm going to skip that also because of the interest of time. So what will happen, you just engage in aerobic exercise only. So resistant training is less appealing to sedentary, doesn't it? So, is it not at all useful? No, it is also useful. It can cause increased muscle formation, skeletal muscle formation, and increase muscle fiber area, but it's cause less muscle hypertrophy. It can reduce the fat mass and reduce the body weight. It has a functional role, but it's not very effective in the treatment or prevention of sarcopenia. Right. So this diagram shows you the strength training in elderly. So it's the most powerful tool against sarcopenia. It reduces the inflammation more. It increases the body composition more, and reduces the insulin resistance more. Right, so there's a few words about nutrition. It is recommended that the elderly people with sarcopenia need increased protein intake for their better muscle strength, the strengthening their muscles and the increased formation. So it is recommended that 1 to 1.2 gram of protein per kg per day is recommended. That means averagely approximately 25 to 30 gram of protein per meal, and their calorie intake per day is 25 to 35 kilocalorie per kg per day. However, this should be tailor-made to the individual. And if they are deficient of micronutrient, they should be replaced. And these pharmacological agents, for a solid recommendation, they need more research evidence. And this diagram is a very good diagram. This graph shows the natural progression of muscle mass and strength with aging. So here, there's a huge individual variation can be observed here with regard to muscle mass and strength, especially in old age. To reduce sarcopenia in old age, we must get started early, right? So we have to aim achieving the maximum peak, take all the measures to keep, maintain the peak during adult life and minimize the loss in old life to ensure good quality of life in old life. Right, in summary, so the sarcopenia is not a rare condition in clinical practice. There had been major attempt to integrate sarcopenia into clinical practice, so use the FACS concept. So there's an increased incidence of probable sarcopenia in our clinical practice and confirmed and severe sarcopenia in some setting. If you have identified the secondary cause as for the etiology for sarcopenia, you have to treat it. And resistant training is the key intervention in prevention and treatment of sarcopenia. Thank you.
Thank you, Dr. Varsha, for that excellent presentation. Any questions from the physical audience here? Yes.
Yeah. Thank you, Varsha. Since there's a lot of trainees as well, with regards to walking speed and get up and go test, the cutoff limits, if you are doing it at bedside, probably if you can tell about any cutoffs for.
All right, okay.
Yeah. Thank you.
So gait speed test.
And gait speed and get up and go test. Yeah.
Get up and go test. Right, okay. So I have not included the limits. So actually I can't remember the exact, the cutoff for to diagnose the poor physical performance. So I'm sorry, I can't answer that question. Yes, it's very with the age, yes. So for the 60 to 70, there's a cutoff, 70 to 80, and more than 80, there's another cutoff. You need not to buy hard, they are there. You just
I think somebody is taking more than 10 seconds to do the tug test, tug test, that would be considered as a positive thing and screening for frailty. So, yeah.
Right.
If you're doing it at the bedside to keep that
As a
probably,
screening,
yeah,
okay.
cut off. Thanks.
Also a comment, I think we spoke of nutrition. You spoke of the high protein intake, which is essential, but in particular nutrition, particularly the proteins which have leucine, is proven to be the building block of muscles. So I think what people advocate is, there's the market, they talk of giving whey proteins, etc., but not all can afford. But there are definitely dairy products, especially the curd and whatever, and then also certain pulses and cereals like chickpeas and green gram, etc. For this region, that's what they advocate. So if somebody is vegetarian, definitely.
Yes.
Varsha, just one question as a rehabilitation, doing the rehabilitation in this country. A person generally, as you said, that they can go into severe sarcopenia soon after infection, and that sort of recovery takes a long time. So do you recommend them to be in a inward sort of institutional rehabilitation for them? Will they tolerate that? Generally what will happen is, if you are in institution, we generally use the full time rehabilitation. They go for morning and evening and that sort of thing. This age with these problems, will they tolerate that, or will they do better from home, maybe coming every other day, something like that?
It's depending on the patient's home, the support, the at home. So the thing is that, for the time being, when they recovered from the acute infection or acute insult, we tend to discharge the patient without looking into their functional status. So they will go down, downwards, after that. So yes, so it depends whether the patient can come as outpatient and get the rehabilitation done, or as institutional level rehabilitations, depend on the patient's family support. And the level of the disability, sir. So it should be individualized.
Okay, in absence of any further question, thank you, Dr. Varsha, for that presentation, and we'll be sharing our certificates at the end of the program. So I'll hand over to Barana to introduce our next speaker.
Thank you, Varsha. So our next speaker is Dr. Joanna Davis. Actually, she is joining online, but it's not live, it's recorded. Because of her work commitment, she can't join online live. And Joanna Davis is a consultant geriatrician at William Harvey Hospital, Ashford, Kent. And she's going to talk, why do we need orthogeriatricians? And we'll start the presentation.
Hello, my name's Joanna Davis, and I'm a consultant orthogeriatrician at the William Harvey Hospital in Ashford, Kent, in the United Kingdom. Thank you very much for inviting me to speak to the Ceylon College of Physicians Specialty Update in Geriatric Medicine. I've been asked to speak today about why we need orthogeriatricians. Now, I've been led to believe that hip fracture care in Sri Lanka is primarily undertaken by the orthopaedic teams. Today, I'll describe how the subspecialty of orthogeriatrics evolved in the United Kingdom and the role of the orthogeriatrician. We will cover hip fracture statistics, the history of orthogeriatrics, drivers that have developed orthogeriatric care, which include the Blue Book, Best Practice Tariff, National Hip Fracture Database, and the role of the orthogeriatrician. It's important to be aware of the statistics as they highlight the significant resource, both financial, personal cost and staffing cost that hip fracture requires. There are 75,000 hip fractures per year in the United Kingdom. They have a £1 billion total hospital cost, which is about 1% of the NHS budget, and 1.5 million bed days per year. It's the commonest cause of accidental death, and it's the commonest reason for an emergency operation in old and frail patients. Looking at the statistics in more detail, these are elderly patients, 95% are aged over 65 years. 35% have at least one comorbidity, and 17% two comorbidities, 7% three or more. ASA grade of 3 to 4 is 70% of the patients, indicating a high operative risk. At least 25% of patients have at least moderate cognitive impairment. 20% of our patients come from institutions such as residential or nursing homes, indicating that they have a high needs for their care. 50% of patients require walking aids or immobile prior to fracture. Despite all of this, 98% of patients go on and have a surgical repair. And the reason we do that is that fixing a hip fracture is important for pain control and also to allow early rehabilitation. Although the patients are frail, elderly with multiple comorbidities, they do have a high mortality of 6.2% at 30 days, but this has improved from 10.7% back in 2007 when the National Hip Fracture Database started collecting data. These are patients nearing the end of their life, and 30% will have unfortunately died at 1 year. As well as mortality, we also see that patients lose function and they may require a move from their own home into a residential home or a nursing home as they're no longer able to look after themselves. So the UK has led the way in orthogeriatric development, so I felt it was really important to touch on the evolution of the specialty. Traditionally, patients were managed with up to 3 months bed rest to allow the bone to heal, and traction was used to restore leg length and help with pain control. From the 1950s, surgery became an option. Surgical intervention aims to improve pain, restore mobility, and reduce deformity. In the 1970s, Michael Devas, who was an orthopedic surgeon, who in fact described himself as a humble carpenter, and Bobby Irvine, a geriatrician, worked together in Hastings in the United Kingdom, and they came up with the principles and concepts of orthogeriatrics, which are essentially the need for prompt surgery and the involvement of orthogeriatricians. By the 1980s, we were collecting data. In Sweden and Scotland, audits were underway. But despite the growing evidence that demonstrated improved outcomes with the routine involvement of geriatricians in hip fracture care, geriatricians were not often involved in hip fracture care. The patients were admitted under the care of the orthopedic teams and were seen by medicine on an ad hoc basis. And these patients had some of the worst clinical outcomes in the hospital population. By the early 2000s, the complexity of older patients with hip fracture was recognised by national guidelines, which suggested that systems of orthogeriatric care should be developed. There was recognition of the need for input from senior geriatricians, orthopedic surgeons, and anaesthetists. And this has resulted in a marked change in management, particularly in the last 20 years. In 2003, the British Orthopaedic Association published their Blue Book. This reviewed all the published evidence for the management of hip fracture and outlined 6 standards of care. They were ambitious. They felt that all patients with a hip fracture should be admitted to an orthopedic ward within 4 hours of presentation. All patients who are medically fit should have surgery within 48 hours, and this surgery should take place within normal working hours. All hip fracture patients should be looked after with a view to minimizing the possibility of developing a pressure ulcer. All patients with fragility fractures should be managed on an orthopedic ward, but they should have access to acute orthogeriatric medical support from the time of admission. All patients with a fragility fracture should have their bone health assessed and also have a falls assessment. And they should be offered a multidisciplinary assessment to prevent future falls. As you can see, as geriatricians, we were really required by these standards. The expected benefits of involving orthogeriatricians included superior medical care, optimal scheduling of fracture surgery, better communication with patients and their relatives, better communication within the multidisciplinary team, initiation of research, education, and audit, reduction in adverse events, and earlier initiation of rehabilitation and more effective use of discharge resources. So we had the standards, but we needed to know that we were achieving them. And this led to the launch of the National Hip Fracture Database, or NHFD, in 2007. This database aimed to provide annual published data of compliance on standards of care, and it allowed hospitals to review their own performance and benchmark against other hospitals. The first report was published in 2009. It contained data from 64 hospitals, which was 1/3 of those eligible. 13,000 patients were included, and this was around 20% of all hip fractures. Only 1 in 5 hospitals that submitted data had routine geriatric care for hip fracture patients, and mortality in 2007 was 10.9% at 30 days. If we contrast this to the most recent report in 2022, we now have data from 175 hospitals, which is all the trauma units in the UK. 65,000 patients have data collected. Pretty much all hospitals have routine geriatric care, so there's been an incredible improvement there. And mortality has come down to 6.2% at 30 days. So I think we can see this has been a great success. And in fact, around the world, people are trying to emulate the success of the NHFD. This is being spread via a website for the Global Fragility Fracture Network. And I've included the link here in case you're interested in looking at what they have to offer. Now, we'd got information from the NHFD, and the question was, what should we do to drive forward improvements? Hip fracture had already been recognised as a common serious condition with significant morbidity and mortality, and the National Hip Fracture Database demonstrated that there was variability in standards of care and outcomes across the country. The Department of Health felt that hip fracture was thus an ideal condition for payment by results in the form of a best practice tariff. So basically, as long as we managed to hit the criteria, we would get a payment. The criteria involved were broadly agreed based on Blue Book standards. The real change was that the standard was that operation should be within 36 hours from admission rather than the 48 proposed by the Blue Book. And a significant financial reward was given for patients meeting the criteria. At inception, that was about £1,300 British. So by offering a financial incentive, it incentivized good care. And it also led to much better data completeness because people wanted to claim the money. And noticeably, there was a significant increase in the number of geriatricians involved in hip fracture care in the UK. These are the current criteria. Patients over 60 are eligible, and you only achieve the best practice tariff if you achieve all 7 characteristics. So essentially, a patient needs to be operated on within 36 hours from admission. They need to be seen by a geriatrician within 72 hours. And we have that longer time period to allow in case there's no orthogeriatrician over the weekend, because unfortunately we don't have 7-day care. During normal working hours, most patients are seen on the day and certainly pre-operatively. You need to do a fracture and bone health assessment. An abbreviated mental test must be done before surgery, and a 4AT test for delirium must be done post-operatively. A nutrition assessment is performed, and also an assessment by a physiotherapist on the day of or following surgery. The criteria have evolved over the years, and in 2022, they were extended to include periprosthetic hip fractures and distal femur fractures. This is a screenshot from the National Hip Fracture Database website. You can see that it's supported by the Royal College of Physicians. There are a number of useful things that we can see on here. You can access the Hip Fracture Database report and look at where you are in the hospital. There are performance charts and key performance indicators. There's also an improvement repository. So hospitals who have identified a gap in their care have done quality improvement projects, and they put the details of these on here to share their good practice so that other people can benefit. There are also, also pamphlets for patients about their hip fracture that can be printed out and distributed, and also pamphlets for carers that can be accessed. So it's a very helpful resource for someone who's wanting to develop their service. There's also access to webinars from the National Hip Fracture Database, which take place quarterly. I've just put up a screenshot of a run chart from my own hospital, the William Harvey. This is information that's open to anybody, including members of the public. You can see the shaded purple area is the patients achieving best practice, and the blue line is operation within 36 hours. So you can see that achieving best practice really does rely on early operation. With respect to the criteria that are linked to geriatric care, we actually do very well. Almost 100% of patients are seen within 72 hours. Pretty much everyone gets a bone health and falls assessment and a delirium assessment. So really it's the surgery that is the limiting factor, and there are various reasons for that, which would be a whole other talk. On the live screen, you can place your marker on any point and it will give you actual numbers. So you can see that on the one I've done for the purposes of this talk, at this time, we were achieving best practice tariff in 68% of patients. We were getting patients to surgery 68% of the time, so they really do mirror it. Orthogeriatric assessment at that point in time was 100%. This is another run chart that you can see. The red line is hours to operation, and the thin dotted line, red line at the top is national, and the darker line is our hospital. So you can see we're doing quite well by getting to operation within 29.9 hours at the point that I hovered over it during the screenshot, and the national average is 39.2%, so you wouldn't get best practice tariff for those ones. The black line is mortality. Now the thin black line along the bottom is national, and the darker line is our hospital, and you can see there is a wax and wane. Currently we're sitting right on the national average. However, there have been peaks, notably in around 2021. At the time of COVID, we had very high mortality in our hospital. And back in 2013, there was also a significant peak. In fact, unfortunately, we were a significant outlier and we were flagged up by the NHFD as having a problem with mortality. So this caused us to take a very good look at our processes, and we had visits from the British Orthopaedic Association to review our practices and just try and improve things. And as you can see, it did indeed result in improvements. So that's the value of the NHFD, keeping an eye in real time on what's going on in all these hospitals. You can also look at key performance indicators. I won't go into great detail here. I'll just look at the admission to specialist ward, and you can see that it's 7%, and this is on a national basis. This just reflects the pressure in the NHS at the moment. We can't get patients directly to our ward because there are so many patients waiting in A&E. So there's plenty of room for improvement, and that's what we continue to strive to do. I wanted to draw your attention to this toolkit, which is on the Royal Osteoporosis Society website. It comes from something called Reduce, and it offers lots of useful bits and pieces that you can use if you want to start orthogeriatric practice in your hospital. For example, there are hip fracture pathway checklists, multidisciplinary team role descriptions, and hip service quality improvements. So just be aware of that. NICE, or the National Institute of Health and Clinical Excellence, came along in 2011 with some standards. These were broadly in line with the Blue Book standards, but they were extended to reflect the whole pathway, from the point when the patient fell and broke their hip and required an ambulance, right through to following discharge to possibly a rehab hospital or back into their own home. So it was a much more holistic guideline, but as I said, broadly along the same lines as the Blue Book. So that's how we got from not being particularly involved in looking after hip fracture patients to joint care in the case at my hospital. So what does an orthogeriatrician do? Essentially, it's a comprehensive geriatric assessment of a patient with a broken hip. There's a multidisciplinary pre-op assessment which involves orthopedics, anesthetics, and geriatrics. And traditionally, this pre-operative care was done by junior doctors, but there's a much higher focus on senior input early now, because obviously these are frail elderly patients with high risk surgery to take place. They wouldn't normally be considered for elective surgery. We purely do the operation for pain control and to allow mobility, and often it's performed as a palliative procedure. So there's a lot to optimize preoperatively. When we see a patient We have to take a history and examination to try and identify and treat the cause of the fall. Things that we're particularly interested in are postural hypotension, arrhythmias, intercurrent infection, and stroke. And we identify and treat these. We take a thorough history and examination. A lot of our patients have cognitive impairment, so we take a lot of collateral histories to establish what happened and what the patient's baseline function is. Baseline bloods and ECGs are reviewed and acted upon. We do medication reviews. In particular, we look at antihypertensives, diuretics, and ACE inhibitors. Patients undergoing a hip fracture generally have a spinal anesthetic, which predisposes to hypotension. So we hold these drugs to try and prevent significant hypotension post-operatively, because this is a significant cause of us not being able to mobilize a patient if their blood pressure is too low in the days following theatre. We also want to try and avoid acute kidney injuries, which are pretty common. We look at delirium prevention. As I said before, we do an AMT pre-op, and after the operation, we do a 4AT to look for delirium. We also put measures into place to try and prevent delirium occurring in the first place. We pay meticulous attention to bowels and bladder. Patients do tend to get constipated, as often on opiate drugs. Urine retention is very common. We do try and get catheters out as soon as possible. Analgesia is important. We give paracetamol regularly and usually codeine as well. We tend to not give non-steroidals due to the bleeding risk in these frail elderly patients. Something that's evolved in recent years is the use of fascia iliac block in the emergency department. This gives a decreased need for systemic opiates, so it's very helpful in that respect. And our ED physicians are doing fascia iliac blocks in almost all of our patients now when they come in the door. We pay attention to nutrition, venous thromboembolism prevention, good skin care, as these patients are prone to pressure ulcers. We have a lot of preoperative discussions about appropriate ceilings of care. This is because these are frail older patients and they may not benefit from organ support or an intensive care environment. They've got poor physiological reserve and they're unlikely to recover from significant organ failure. So we need to set realistic expectations with them and their families as to what can be achieved. We have written protocols which ensure that best care is embedded in practice. We identify and treat correctable comorbidities so that surgery is not delayed. Things that we pay particular attention to are anemia, because of course there will be operative blood loss. So if someone's already anemic and they get more anemic, there will be an increased risk of myocardial or cerebrovascular ischemia. So we will often transfuse a patient preoperatively to optimize them. Around 25% of our patients are on DOACs. We don't see so much in the way of warfarin now. So it's very important for us to know the indication for the anticoagulation, and then we need to reverse it. Obviously, we're aiming to operate within 36 hours. We use local protocols for reversal. The DOACs don't have reversal agents, but generally in a patient with normal renal function, they will have washed out within 24 hours. So that leaves us time, so long as we stop the anticoagulation as soon as they come in. Warfarin needs to be reversed with vitamin K. A lot of patients are on antiplatelet drugs such as clopidogrel. Now, if you were having an elective operation, that would be stopped 7 days prior, but we don't get the opportunity for that with a fractured neck or femur. So the operation does go on regardless. It's just the patient can't have a spinal and there is a slightly increased risk of bleeding. Patients may have intercurrent illness or may have had a long lie on the floor before they could get help. So they're often volume depleted, so we correct that. We correct electrolyte imbalance. We make sure that diabetes control is optimized and also heart failure is optimized. We correct any cardiac arrhythmias or ischemia, and we treat for chest or urine infection. Some other special considerations, we see a few patients who are on dialysis and their operation needs to be fitted appropriately around their normal dialysis schedule. Patients with a pacemaker will need a pacemaker check if there's a concern that it's malfunctioning, and patients with a defibrillator will need liaison with cardiology so that it can be turned off to allow the operation. In the event that we discover a new cardiac murmur, such as possible aortic stenosis, the decision is that echocardiogram should not delay surgery. Now, this is because if we find a significant aortic stenosis, the patients are not going to receive definitive treatment, such as a TAVI or a valve replacement before the hip operation. So the anaesthetists are made aware and treat the patients as though they have significant aortic stenosis. We still see people with mechanical valves, and their anticoagulation is managed according to local protocols. Now, I keep saying we are aiming to operate within 36 hours. All the evidence is the sooner we operate, the better, because patients' pain is controlled and they're up and about. So that means that they're at less risk of chest infections, venous thromboembolism, and all those other associated events of lying in bed unwell. Now, the Association of Anaesthetists of Great Britain and Ireland had a working party in about 2011, and they came up with reasons that it would be appropriate to delay surgery, because obviously we're not going to operate just because we don't want to miss the 36 hours. So patients who may need their operations delayed include those whose hemoglobin is less than 8, whose plasma sodium is less than 120 or more than 150, or have a potassium less than 2.8 or more than 6. Anyone with uncontrolled diabetes, uncontrolled heart failure, a correctable arrhythmia with a ventricular rate more than 120, chest infection with sepsis, and a reversible coagulopathy will be delayed if it means that we think we can optimize them to make the operation a bit safer. Now, there are unacceptable reasons that operations are delayed. They still happen, but operations should not be delayed just because there's a lack of theatre space or ITU bed, because they're awaiting a echocardiogram, because there's not an orthopaedic surgeon of sufficient seniority available, or to correct minor abnormalities. And this is useful to have this list, because then everyone knows what we're trying to achieve to get someone optimized up to a level that's acceptable for surgery. In the peri and post-operative period, orthogeriatrics continue to play a key role. We see the patients every day. This allows prompt recognition and treatment of infection and other medical issues. We do a lot of communication with patients and their family and carers. We update them on where they are clinically and also the plan going forward, because patients have often lost their confidence or are worried about how they'll manage at home. So we spend a lot of time reassuring them and making plans to allow discharge planning. We make decisions about surgery and its timing. We undertake a bone health assessment. So we consider whether a fracture might be a pathological fracture due to myeloma, metastatic disease, or perhaps a pathological fracture associated with bisphosphonates. The majority of fractures that we see are due to osteoporosis, and we follow the NICE guidelines for the management of these. So if a patient's under 75, we would arrange a DEXA scan as an outpatient and then treat if required. Patients over 75 are treated presumptively. This is with either an oral or intravenous bisphosphonate, or with denosumab if they have poor renal function or other contraindication. So we get all of that going whilst they're in hospital. We undertake a falls assessment on all patients. That includes a lying and standing blood pressure, ECG, visual check, ensuring they have appropriate lifestyle advice. We lead a multidisciplinary meeting. So every morning on our ward, we have a meeting with the therapists, nurses, doctors to discuss which stage the patient's at in their pathway. That way we know exactly where the delays are and what needs to be addressed. We are involved in rehabilitation and discharge planning. And we also play an advocacy role, because a lot of these patients are frail and cognitively impaired. It's important that they and their families understand their frailty and that they have appropriate ceilings of care and appropriate expectations as to what level of function they will be left with. So that's in a nutshell what an orthogeriatrician does. I thought I would do a case history just to illustrate a fairly typical patient so that you get some flavour for how we work. So Mrs. Smith's an 87-year-old lady. She's got a Rockwood clinical frailty score of 6. She presented to the A&E with a history of an unwitnessed fall at home while walking to the toilet. Her daughter heard a thud from downstairs and found her on the floor, so she didn't actually see the episode. Mrs. Smith was unable to get herself up, so her family put her back to bed, but she complained of severe pain in her right hip and was unable to wait there. The family called an ambulance. and she arrived at hospital. Mrs. Smith herself had no recollection of the event. The family reported she'd had one other fall with no injury over the past year. So already in the first stages of seeing Mrs. Smith, we're undertaking a falls assessment. Mrs. Smith's past medical history includes CKD stage 3, a recent diagnosis of dementia, hemorrhoids, atrial fibrillation or warfarin, rheumatoid arthritis, hypothyroidism, a stroke which left her with mild residual left arm weakness, an abdominal hysterectomy at the age of 35, which would be a predisposing factor for osteoporosis, and no history of fragility fractures. She lives in her own home. Her daughter and granddaughter have recently moved in following her dementia diagnosis, and they are supporting her. She has no formal outside package of care, but the family help with cleaning, cooking, shopping, and washing. Mrs. Smith is mobile with a Zimmer frame, and she's a non-smoker who drinks very occasionally. Medications-wise, she's on levothyroxine, warfarin, folic acid, B12, paracetamol, and bisoprolol, and has no known drug allergies. On examination, she had an early warning score of 1. Now you can see that her heart rate is 131, which would preclude her having an operation or make it less likely to happen. So we need to get that under control. Her AMT is 3, so we took a collateral to find out what her normal state of function was. She was alert but not orientated to person, place, and time, and she was restless and agitated, resisting physical examination, consistent with an acute delirium. She appeared dehydrated, and her right lower limb was externally rotated and shortened. The following investigations were requested by A&E and reviewed by the orthopaedic and orthogeriatric teams. She had an X-ray pelvis, routine blood tests. We also do B12, folate, vitamin D, and calcium in patients who have had a fracture. Patients who are desaturating have a chest X-ray. This lady had a CT head as per NICE guidelines. They recommend a CT head for any patient who's on warfarin, who's confused, and had an unwitnessed fall. An ECG was performed and a lying and standing blood pressure is done, but obviously we can't do that preoperatively as a patient can't stand. X-ray of the pelvis confirmed a right hip fracture. Blood test showed acceptable full blood count using these LFTs and calcium. INR was high at 3.7 and a vitamin D was low at 21. Excuse me. CT head was performed. This showed small vessel disease and atrophy, but no evidence of bleeding. ECG showed atrial fibrillation with a rapid ventricular rate. So from all of this assessment, a problem list was generated. Mrs. Smith had had a fall which was probably multifactorial. Her dementia probably resulted in poor safety awareness. Previous stroke may have caused poor strength and balance. She's frail, and her atrial fibrillation is not rate controlled, which may have contributed to her fall. Second problem is a right intracapsular neck of femur fracture, for which she needs an operation. Number 3 is atrial fibrillation with a fast ventricular response rate. Number 4 is a raised INR in a patient on warfarin. Number 5 is likely delirium secondary, and that's probably due to a number of reasons. She's in pain, she's out of her normal environment, and as you'll see on the next page, she was in urine retention. And she's also got osteoporosis as a 6th problem. So we go through that list working on optimizing those factors. Mrs. Smith was managed by giving vitamin K to reverse her warfarin. You need an INR of 1.5 or below for a spinal anesthetic. So she was given vitamin K and her INR was to be rechecked in 6 hours' time. Her regular medications had not been prescribed by the time she was seen, so they were written up and bisoprolol stat dose was given to control her atrial fibrillation rate. She was given intravenous fluids. A bladder scan was done, which showed she was in urinary retention, so she was catheterized. She was carefully examined when she was a bit calmer for any evidence of an infection that might be triggering fast atrial fibrillation. And a discussion was held with her daughters about ceilings of care. It was felt that she was quite frail, and it was agreed with the family that in the event of her deterioration, she would not be for attempted resuscitation or for transfer to intensive care. It's important to make these decisions before the operation in case a patient deteriorates in theatre. With respect to pain control, Mrs. Smith received a fascia-iliac nerve block in the emergency department. She was transferred to an orthopaedic hip fracture specialty ward, and her case was discussed by the orthopaedic trauma meeting team in the morning. It was decided that she should be for an operation. Fortunately, her INR had improved to 1.5 post the vitamin K, and her heart rate had settled down to 76. So she was medically optimized for theatre. She was reviewed preoperatively by an anaesthetist and had a right hemiarthroplasty operation later that day. Mrs. Smith was reviewed by us each day following surgery. She came through the surgery quite well. She did develop a further delirium post-operatively, and she was treated for a presumed lower respiratory tract infection. We saw that she had a low vitamin D, so we started her on vitamin D replacement, and arrangements were made for her to have intravenous cylindronate once that had been replaced. Usually we give a 9-week course of vitamin D until a patient's vitamin D replete before we give this drug. Now we are switching more and more of our patients on warfarin to DOACs just because they're so much easier to manage. So a discussion was held with her relatives and we changed her warfarin to a DOAC. And after all of that, she was seen day 1 post-operatively by the physiotherapist. She was got out of bed, which is our normal expectation. And she actually did quite well once she'd settled down on the ward. She engaged with the therapies team and she was transferred to a local community hospital for further ongoing rehabilitation. And I think she ultimately got back home. So that was a nice story for her. So in conclusion, OrthoGeri's encompasses a multidisciplinary approach to patients with a fragility fracture. And I think we've demonstrated that greater involvement of geriatricians has improved in better outcomes for fracture patients. And the way that we work can be extrapolated to other fragility fracture patients. It's just getting the resource and the number of geriatricians that we need to extend our care to all the patients that would benefit from our help. Thank you very much for the opportunity to speak to you. I hope this has been thought-provoking. I've left a list of references and also useful resources, of which there are many online, in case you're interested in further developing your resources in Sri Lanka. Many thanks.
On behalf of the college, I would like to thank Dr. Joanna Davis for spending her time to do the recording and sending across to enlighten the audience. Since it's a recorded one, there will be no questions, so I'll ask Baran to introduce the next speaker.
Further, I would like to thank Dr. Kistri Karunathilaka. He's a close friend of CCP and consultant physician who coordinated the JAWS lecture to us. And next, we are moving to case discussions. I would like to invite Gauri to the podium. And there will be 2 case discussions. One is by Balakrishnan Gaurashankar, and the other one is by Dr. Sithira Senaviratna. And another close friend of CCP, Prof. Duncan Fawcett. He's joining virtually today, and he's the expert panelist for these case discussions. After each trainee presents their case, the Duncan will give a feedback to us. So the first one is the Gauri Shankar. He is working as a senior registrar in the geriatric medicine unit of Teaching Hospital, Peradeniya. He is going to talk to us on the hydra of multimorbidity, confronting the many-headed adverse effects of wrong medication in a geriatric patient. Over to you, Gauri.
Thank you, sir. And I would like to thank the Ceylon College of Physicians as well as the Sri Lanka Association of Geriatric Medicine for giving me this opportunity. And sir told about my topic. So you may wonder what a non-sarcopenic gentleman doing in the front page in a geriatric presentation. Ladies and gentlemen, I would like to start my presentation with a small story. So I'm sure you all have heard about Hercules. Hercules from the Greek mythology. So Hercules was found to be guilty for some wrongdoing, and his king banished him. And he asked Hercules to undertake certain tasks. So as for the second task, so managing a geriatric patient was not a task by Hercules, but one of the tasks was very similar to how you manage a geriatric patient. So the second task of Hercules was to manage this vicious snake. That was a sea snake which had many heads. So every time somebody cuts one of the heads off, the monster developed or regrew 3 or 4 more heads. So Hercules had to make up a specific plan to kill this monster. So managing a geriatric patient is not very different from this situation. Every time when we try to manage one problem, we see 3 or 4 more problems appearing in the patient. Right. So we'll move on to our patient. So my patient is Mr. A. He's a 73-year-old gentleman from Piliandala, and he was living with his wife and daughter. He was admitted to the orthopedic ward following a fall and a hip fracture. He's a diagnosed patient with type 2 diabetes, hypertension, dyslipidemia, as well as idiopathic Parkinson's disease. The patient did not have a very proper follow-up. The patient was followed up at the GP, to whom he did not visit very frequently, and he was not very regularly taking his medications. And the patient was complaining of poorly controlled Parkinson's symptoms all over, and GP had recently started the patient on Benzexol. And with this, a few weeks ago, the patient's wife had a stroke, and she became dependent on her activities of daily living. So to help her parents, the daughter moved in with the parents. And with that, after a few days, the patient had a fall. And he remembered, and he developed right-sided hip pain. And for that, the patient, although he could not walk, did not go to the hospital. He asked his daughter to bring some medication from the pharmacy, which he took. But the next day, the daughter found him unconscious in the bed. So they brought him in a hurry to the medical ward, to the accident ward, and the patient was diagnosed to have major hypoglycemia. And because of the limb appearance and the pain, an X-ray was done, diagnosing a right-sided hip fracture. These were the medications that the patient was on. The patient was on an atorvastatin 20 milligram Noctale, and for the dyslipidemia, losartan for hypertension, metformin and glycoside for diabetes, Syndopa and Syndopa CR preparation, and Benzexol for the Parkinson's disease. Right. Here, the patient was referred to us by the orthopedic surgeons. So we went to the orthopedic ward. We did what we usually do. We did the comprehensive geriatric assessment. So the comprehensive geriatric assessment, it's a multidisciplinary, diagnostic as well as therapeutic process, identifying the patient's not just the medical, but also the psychosocial and functional limitations in order to develop a coordinated plan to maximize the overall health with aging. So there have been many studies about this comprehensive geriatric assessment shown to have improved ADL and quality of life in all acute, chronic, and also the community settings. And it also has shown to reduce readmissions and hospital visits in the chronically ill patients. So let me tell you how we did, what we found out in the patient's comprehensive geriatric assessment. So we found out certain major problems and certain minor problems. The first problem that we found was the major hypoglycemia. We were not sure why the patient developed a major hypoglycemia at that point, and the hip fracture. So what caused this fall and the hip fracture? And I mentioned that the patient had a poorly controlled Parkinson's disease. So despite of having all this medication, 3 medications for the Parkinson's, the patient's Parkinson's disease was poorly controlled. And also the patient was overall a very frail elderly man. So these were our main problems. With this, we had some other problems as well. So let me tell you one by one how we tackled all these the problems one by one. First, the major hypoglycemia. So when the patient was started on Benzexol, as we expect, as geriatricians would expect, the patient developed dry mouth, and with that, the patient had difficulty in eating and loss of appetite. And also, the patient, after the fall, asked his daughter to get some medication from the pharmacy, which turned out to be, unfortunately, NSAID, diclofenac sodium, following which the patient vomited his diet, but he had taken the medication, which these two are the most important causes for this patient's major hypoglycemia, and also hip fracture, high catabolic state, again, and the patient having a background delirium. I'll speak about that later, and also the inappropriate polypharmacy. All these factors resulted in this major hypoglycemia. And after this assessment, we also noted some important points in the patient's history. Patient previously had poor adherence to the medications. The patient, despite of having 3 medications, about 6 medications, did not have a good, well-controlled Parkinson's disease as well as the other diseases. So he had hardly any trust on his medication. And he also complained of some episodes of minor hypoglycemic symptoms previously as well. And with this, the patient was afraid to take his medication. And the drug regime was very difficult. We saw that the patient was taking 5 different doses of Syndopa. And after the Benzexol was started, it was very difficult for the patient to tolerate that. So with all these, the patient did not comply to his medical prescription. But when the wife developed this minor stroke, and when the daughter moved in, she took the problem to her hand, and she started giving the medication to the patient. So you can see, ladies and gentlemen, that a small thing like the daughter moving in, a small issue like this might result in a fall in a geriatric patient. So as the daughter started looking after the parents, she gave the medications properly, although the patient was refusing, which was bad to our patient. Patient developed a hypoglycemia and fell down. So about the fall. So we found out that the patient had multiple unattended intrinsic and extrinsic risk factors. So we saw that the patient possibly had minor hypoglycemic episodes as well, and delirium, and that was with Benzexol, and Parkinsonism. The patient, despite of all the medications, had bradykinesia as the salient feature, and the patient had difficulty in moving around. So that was one reason. And we identified certain other risk factors from the patient's comprehensive geriatric assessment as well. The patient had bilateral cataract resulting in poor vision. The patient had sarcopenia. Patient had postural hypotension. The patient, for the age, the long-standing diabetes, and also the Benzexol, all would cause postural hypotension. The patient had that. And the symptoms, we could not measure the blood pressure of the patient, but the patient had symptoms. With that, we identified few environmental risk factors as well. So everything together resulted in the patient's fall. And with this, the patient had a long-standing poorly controlled diabetes, old age, and low BMI, all are risk factors for osteoporosis. The patient ended up having a fragility fracture. About the delirium, even when the patient was at home, when the patient was on Benzexol, the patient had features of delirium on and off. The patient had reduced activity, reduced appetite. With that, after the patient got the hip fracture and admitted to the ward, the patient, we noted that the patient was very drowsy in the ward and not talking to any family members, and had some confusion with fluctuating consciousness. With this, we diagnosed delirium in the patient, and we identified many important risk factors. Imagine a busy orthopedic ward setting. The buses sounding all the time, with the staff changing their duties all the time, and every time when the patient sees somebody coming and giving his medication, that's a new person. And a new doctor coming and asking regarding the patient with questions, and attendants sometimes scolding the patient, all this unfamiliar environment and faces, that's a very important risk factor for delirium in the elderly patients. And also the pain, which was poorly managed initially, that also an important risk factor. Then the tubes and cannula. The patient had, with the Benzexol's effect, had a urinary retention in the ward. So the patient was inserted the patient was inserted a bladder catheter. With that, the patient had cannula and IV medications were going on. With this, the patient again, that was again a risk factor. And poor mobility. The patient was put on a bar bed. Patient could hardly move. And with the hip pain, the patient could not walk. All these factors resulted in delirium in this patient. And the more interesting, poorly controlled Parkinson's disease. What are the reasons? So first of all, we identified there are about 5-6 reasons why the patient's Parkinson's disease was poorly controlled. First one, the patient had very troublesome early morning symptoms. So the reason for that was that the patient was taking only a very small dose of this controlled release preparation. To overcome that problem, the patient was taking a 4 a.m. Syndopa dose. So the patient usually woke up at 7:30 a.m. So what's the use of a 4 a.m. medication except for the patient to wake up? As he wakes up to sit in the bed, there was none. And 8, 12, 4, and 8 p.m. medications, the patient took all these doses with either meal or tea, with high protein, say either meat or milk. So the absorption of Syndopa was less with all this protein intake, again resulting in poor control of Parkinson's symptoms. And the patient, because he had no trust on his medication, had poor adherence, and also we thought that the patient possibly had a cognitive impairment in the background, which we plan to assess later, would have resulted in poor adherence. But without assessing all these symptoms, the patient was very easily started on a benzexole. So why, as geriatricians, we don't like benzexole? The American Geriatric Society, the Beers criteria, marks it as a potentially inappropriate medication, and also the STOP criteria, the screening tool of older person's prescription, again marks benzexole as a potentially inappropriate prescription for persons above 65 years. So what's the reason? That's because of this all adverse effects. So you can see the famous mnemonic on the side. In the elderly, especially, cognitive side effects like delirium and long-term use causing dementia are the important side effects. And constipation, urinary retention, dry mouth, and hypotension, all this further worsening the delirium was the reason for the patient to, why we advise against the patients taking benzexole. And so those were the problems, the major problems. Other than these major problems, we identify certain other problems as well. The patient had inappropriate polypharmacy, and the patient had a very significant functional limitations with the hip fracture, and even prior to that, the patient had a possible sarcopenia. And we anticipated a lot of problem during the patient's rehabilitation, and possible background cognitive impairment, I spoke about that. And we also identified certain social risk factors like home infrastructure, which resulted in the fall. And we also thought that might be problematic to the patient once he goes back to his home, and also the very significant caregiver burden. Imagine the daughter looking after both dependent parents, the mother and father. So those were the problems we identified from our comprehensive geriatric assessment. Right. So why Hydra? The monster Hercules killed. The problem with the geriatric patient is very, very similar. Problems with the multimorbid geriatric patient is very, very similar to this Hydra. So these patients, I have the diagrammatic representation shows the multiple medical problems, medical and other problems that the patient had. Imagine looking after only one problem, one of these problems. Say, if we try our best and control all the medical problems, the next time, maybe in a week or 2 weeks' time, the patient would come back with another fall. And if you if you sort out all these issues, and if you send the patient without looking after the patient's home environment, again, that's going to be a caregiver, that's going to cause significant burden to the daughter, and that's going to adversely affect the patient's rehabilitation as well as healing process. So, ladies and gentlemen, that's very similar. Like you have to look after all the problems together. You have to focus on each and every aspect of this geriatric patient's problem together. So, about multimorbidity. So that's the presence of two or more chronic conditions that collectively have an adverse effect on health status, function, or quality of life that require complex healthcare management, decision making, or coordination. That's the definition. So that's very prevalent. That's very common among elderly. So that's 34% over 65 years, going up to 50% over 74 years. And the adverse effects of multimorbidity, it's not just the patient's health, it increases in healthcare utilization as well. It causes frailty, it further declines the patient's functions, it increases mortality, it worsens the cognitive impairment, and because of the many medical conditions, the patient has to be on polypharmacy, and patient has to somehow bear all these adverse effects, and also the quality of life decline, and which ultimately would result in depression, and altogether would increase the healthcare cost as well. So I have adapted these 3 steps of managing multimorbidity in elderly from the NICE guidelines. So you can simply divide the management into 3 points. The first is a patient-centered management. So that is by doing the comprehensive geriatric assessment, not just the problem the patient presented with, see the patient as a whole and assess the patient as a whole, and to consider the patient's care goal. So we speak with the patient as well as the patient's family members, and we develop a goal plan, and we stick to that plan, and we manage and we plan the management according to that. And then the second point would be diagnosis-centered assessment. Here the patient, we we had to look after a lot of we had to think for the possibilities of the causes for many medical problems, such as the poorly controlled Parkinson's disease, hypoglycemia, osteoporosis, like that. We have to consider the medical conditions, not just the medical conditions like diabetes, hypertension. Also should consider problems like frailty, fall risk, quality of life, and also the activities of daily living. With this, we assess the medications and we do the medication-centered assessment. That is again very important in the elderly. So we are told every time the patient sees a doctor, the medications have to be reassessed. The doctor has to see each and every medication, whether it's really needed. At that point, whether we can stop the medication, whether the patient needs something else. So the medication assessment has to be done every time the patient sees a doctor. And we have to consider non-pharmacological approaches such as physiotherapy and even other injections other than this, even other activities other than this pharmacological management. With all this, we can come to a agreed therapeutic plan that is agreed by the patient as well as us, and then we should proceed with the management of this patient. So let me quickly go through the management, what we did to our patient. So we initially spoke with the patient as well as the daughter, and we came to a conclusion that what's really needed for the patient. Then we did the comprehensive geriatric assessment. I spoke about the findings. Then we did the preoperative optimization. We had to manage the patient's delirium, we had to optimize the patient's sugar, and we had to prevent the patient having bed sores, and we did the preoperative management. And we discussed with the orthopedic team, and surgery was quickly done, and hip fracture was corrected. And then we planned on the osteoporosis treatment. In Sri Lanka, we don't usually start the osteoporosis treatment immediately if we can help to get the patient down in 1 month's time. That's what the orthopedic surgeons prefer for a better healing. So we did that. And then we adjusted the patient's anti-diabetic medication. So we initially managed the patient with insulin. Then we went ahead and adjusted the patient's anti-diabetic medication. We basically stopped glycoside. We increased the patient's metformin. So we knew that the patient had loss of appetite, but the patient was on metformin for a long time, who tolerated that very well. So we could not actually find why the patient was basically started on glycoside in the first place. So we went back to patient's usual metformin, which is better in the elderly. Then we educated the patient and caregiver regarding the Parkinson's disease and what the patient should do. And then we stopped Benzexol. Then we adjusted the levodopa timing. So we asked the patient usually woke up around 7 o'clock. We asked the patient to take his first dose at wake at 7 a.m. And we asked the patient to wait for about an hour to have his breakfast at 8, his usual time. Then when the patient was not taking any meals at 10 o'clock, we asked him to take his second dose. And 2 hours post-lunch, the third dose. And the time in between the dinner and the tea, the fourth dose. So with this, we also educated the patient and the daughter about the importance of not taking the levodopa tablet with protein-rich meal. And also, we increased the night long-acting dose, which we thought would help the patient's early morning symptoms. And we strongly advise the patient on physiotherapy and regular, following his medication plan. And further, for all the other problems that we identified in the patient's comprehensive geriatric assessment, we planned the management. We referred the patient to the ophthalmologist for the cataract surgery. Poor vision is a very important risk factor for falls, so we referred the patient, and we started the patient on physiotherapy. The patient had features of sarcopenia, patient had a fall, and we knew that the patient was going to have more falls if we don't treat that at that point, and the Parkinson's disease again. And we discussed with our social service office and occupational therapist. Kalubal, we had a very good team. So we planned a home visit of this patient, and we addressed the patient's caregiver burden as well. We spoke to the daughter. We thought that with time the patient's conditions will improve, and also we advised her to get help from some other sibling as well, whom could help, who are living close by. And the most important part, we asked the patient to maintain the Parkinson's diary. So the patient's Parkinson's symptoms, we would not know how well it is controlled and why the patient is not taking the medications unless we have a documented proof how the disease control as well as the patient's complaints has been. So usually, whichever the patient who complains of a poorly controlled Parkinson's disease, we always advise them to have a Parkinson's symptom diary, which we have found has been very helpful in the management of Parkinson's disease patients. So the way Hercules managed this monster Hydra is not very different from how we should manage this multimorbid elderly patients. So you see, Hercules being this demigod and legend, he was not shy to ask help from his nephew. So Hercules made up a plan. So he called his nephew. He asked him, whenever Hercules cuts down one of these heads, he asked the nephew to cauterize that, to burn it down, so that way the head will not regrow. How we manage a geriatric patient is not very different at all. We do the same. So the multidisciplinary approach. So this is the cover page and of one of the agenda, that is the British Geriatric Society magazine newsletter. So this is one of their issues about multidisciplinary teams. So they have mentioned about multidisciplinary teams that the secret weapon when it comes to caring for older people. So that really is the secret weapon. So the importance of MDT, that is immense in the geriatric practice. So that brings together different skills and expertise to one place, carrying one patient. And so that is the core to successful comprehensive geriatric assessment. A doctor cannot completely do a geriatric assessment alone. And improves the patient's outcome. That there have been researches and it's shown to improve patient outcome and experience, significantly reduces functional decline as well as better ADL outcomes, and also improves the mental health. And it's shown to prevent hospital readmissions, reduce A&E attendance, and also reduces the hospital's stay length. And more than everything, it improves the continuity of care. So I spoke about multimorbidity, how it affects how common that is among the elderly patients and how it affects the elderly geriatric population. And the way of tackling that by doing the comprehensive geriatric assessment and the management of multimorbidity, I outlined the NICE guidelines. And also at the end, I spoke about the importance of multidisciplinary approach. And that concludes my part of the presentation.
Thank you, Dr. Gabrishanga. Yes, I would like to invite Professor Duncan Forsyth to comment on that. Good morning, Professor Duncan. I hope you are live joining us now.
I hope you can hear me.
Yes, sir, we can hear.
Yes, we can hear.
Great. So there seems to be a little bit of lag, not from you to me, but from me to you. Excellent presentation, particularly liked the graphics. I'm going to start with the term multidisciplinary. You're absolutely right that geriatric medicine is a team sport. And I often use the analogy of a football team. Given the recent demise of the wonderful Sir Bobby Charlton, I'm going to use him as my exemplar team player. When Bobby Charlton was playing for England or was playing for Manchester United, he was a fabulous player. But if you put him out on the pitch alone, England wouldn't have won the World Cup in 1966. He needed all the other members of the team. So remember that it is a team effort. And whilst geriatricians are often seen as the leader of the multidisciplinary team, we're nothing without the others. However, I want to introduce to you, if you're not familiar with it, the term interdisciplinary. And the importance of differentiating between multi and interdisciplinary is that sometimes multidisciplinary teams will work in silos. The doctors do their bit, the nurses do their bit, the physios do their bit, OTs do their bit, and so on. Interdisciplinary means that if your physio is ill or goes off on maternity leave and isn't replaced, that others can take over because they understand the skills of the physiotherapist and have some of those skills themselves. So as a doctor, for example, you should be able to do a timed up and go test. You shouldn't devolve that to somebody else. If all the team's there, it may be better for somebody else to do it and allow you to move on to the next bit of your jobs. But you should know how to do a falls risk assessment, and you should have some basic knowledge of the exercise regimes that a physio might give to someone who is recovering from a hip fracture, for example. So that's the concept of interdisciplinary team working. And there is good evidence that interdisciplinary teams function better than multidisciplinary teams. And again, I would use a sporting analogy, and I'll use the French rugby union team. They are infamous in that sometimes they all turn up together mentally, and when they do that, they are a fabulous and very difficult team to beat. But very often, the French rugby union team have a tendency not to all turn up. That is, they don't gel, they don't work together, they don't cover each other, and they, in those times, they're very dysfunctional, and they usually get whooped. So we always hope that they are dysfunctional when they are played by England. The next thing that I would say is that you've given a brilliant example of how geriatricians and their teams must persevere, and when they've found one problem, not sit back and feel that they've solved everything, but must look for the other problems. So to untangle the issues. And the other metaphor is that of Occam's razor. Now, Henry of Occam was a 16th, an English philosopher in the 1600s who said that the simplest explanation was always the right one. Well, in geriatric medicine, that's rarely the case. So when you found one problem, look for the others. And using your Hydra metaphor, also remember that when you solve a problem, you might generate others, just as the daughter did, by making sure, by solving dad's failure to adhere to his medication, by supervising his medication and making sure that he took it, she generated another problem, which was the adverse effects of his medication being relatively overdosed, because presumably people who kept increasing the doses of his medications, not realizing that part of the problem was he wasn't taking them. There was a point that if there had been time for questioning with the previous presentation on orthogeriatrics that I would have made, which is relevant to your presentation as well, I think, which is don't miss the opportunity to train the future orthopedic surgeons. So, for example, in Cambridge, where we have senior geriatricians, orthogeriatricians embedded in the trauma and orthopedic unit, the question is, what junior trainee support do they have? And that trainee support actually comes from orthopedics. So it is the orthopedic trainees who support not just the orthopedic surgeon, but also the orthogeriatricians. And what you require are orthopedic surgeons who are, like that one that worked with Bobby Irvin, recognize that they are humble carpenters, and they're at their happiest when they are cutting and mending, that is in theatre. They need to release their trainees to support the orthogeriatricians who are supporting the orthopedic surgeons in having good outcomes. Now, of course, the more senior of their trainees will need to go to theatre because they need to know how to become humble carpenters as well. And our more senior trainees can replace them because our more senior trainees need to be trained to be orthogeriatricians. And a point that I've made many times when I have either been remotely or physically in Sri Lanka is you'll never have enough geriatricians. So it's very important to embed these skills into other specialties. I think that will do for my pearls of wisdom at the moment. But a great presentation, lovely slides, and a very smooth presentation. I commend you on that.
Thank you, Duncan. And we will move to the last case scenario, the case discussion by Dr. Sithira Seneviratne. Sithira is a Sri Lankan geriatric trainee He is working in John Radcliffe Hospital, Oxford, as as a specialist registrar in geriatric medicine. So it is because he's currently working. We have the recorded case discussion. I would ask to IT team to start the recording.
Right. Good afternoon. I'm Sithira. I'm one of the geriatric medicine MD trainees from Sri Lanka. And first of all, I would like to thank Ceylon College of Physicians for giving me this opportunity. So today, I'll be discussing a case scenario, and Professor Duncan Forsyth will discuss on the case after my presentation. Today, I'm going to discuss a story of a 94-year-old female who was admitted following an unwitnessed fall at a community rehabilitation hospital, and she was found to have a left-sided intracapsular neck of femur fracture. And seems like this is her third hospital admission during the last 3 months. So she has been in and out of hospital for last 3 months. 1 month back, she was admitted to the medical ward, again following a fall, and this time she was found to have a chest infection and acute delirium and was discharged 2 weeks ago to a community rehabilitation hospital for further rehabilitation, where she had the second fall. And during this admission, a do not attempt resuscitation decision was made after discussing with her son and recorded. Going through her past medical history, she is diagnosed with type 2 diabetes mellitus, hypertension, a history of transient ischemic attack, and bilateral knee joint osteoarthritis, iron deficiency anemia, and hay fever. Her medications were rationalized during her last admission to the medical ward. So at the moment, she was on a few medications, including losartan, clopidogrel, atorvastatin, metformin, and paracetamol. Going through her social history, she lived with her son, and seems like 5 years ago, her son moved to live with her because she was not coping alone at home. 1 month prior to her admission to the medical ward, she used to walk indoors with a wheel Simmons frame. So she had difficulty in walking. So she used to use a wheel Simmons frame, and her son used a wheelchair to take her outdoors. And she had the memory impairment. She has had worsening memory impairment over the last 5 years. And before admitting to the medical ward 2 months ago, she needed prompting for almost all the activities of daily living. So even though there's no formal diagnosis of dementia, so this raises the suspicion that probably this patient has undiagnosed dementia. And since her discharge from the first admission 3 months ago, a carer used to come every day morning to help with her washing, dressing, and son helps with the activities of daily living during the daytime. So this is the initial assessment after the fall. She was confused, and her AMTS, which is the abbreviated mental test score, which we do as a part of initial assessment, is 1 out of 10. She could only recall her date of birth, and her blood pressure, pulse rate was stable, and she had a forehead bruise suggestive of possible head impact when she had this unwitnessed fall. And the left leg was externally rotated, which suggests of that left side neck of him fracture. And her chest, abdomen, cardiac, and rest of the neurology examinations were normal. Her initial investigation showed mild neutrophilic leukocytosis with CRP of 45, probably secondary to neck of femur fracture, other than any other infection. And electrolytes and renal functions were normal. Her ECG was normal. Her chest X-ray was normal. So she underwent a CT scan of her brain because there was a suspicion of head injury because she had a forehead bruise. What can you see in this brain scan? So you can see significant temporal lobe atrophy. And in the coronal section, you can see how the mesial temporal lobes are atrophied. So suggestive of possible Alzheimer's pathology. And given her history of memory impairment over 5 years and currently needing prompting for all the activities of daily living, we thought like possibly this patient is having moderate to severe dementia. So remember the fact that she had a TIA, so could be mixed etiology dementia. And this is an X-ray of her pelvis. So what can you see here? So there's a fracture involving her left side neck of femur. There's some fecal loading. Possibly she's having some constipation. Right. So what would you do for this type of fracture? Would you do surgery or would you manage non-operatively? So the surgical option is the best option, even though she's having a lot of comorbidities. So she underwent a left side hemiarthroplasty, hip replacement on day 2 of admission. And there were no intraoperative complications. She was found to be more confused on post-op day 1, so and a bit agitated. Her MTS was repeated at this point, which was 0. And so agitation seemed to be more at night and seems to be calming down in the presence of a person by the bedside. So she's having post-op delirium, and then she refused physiotherapy. So post-op delirium after hip fracture is very, very common. And the incidence can vary from 35 to 60% in studies. So in a recently conducted study in Sri Lanka, in Colombo South Teaching Hospital, we have found that so delirium in our population after hip fracture is more than 50%. It's a very common problem. And pain medications like opioids, anesthetic drugs, constipation, dehydration, and postoperative infections are common precipitants. And this is associated with increased mortality. On post-op day 2, she had new oxygen requirement. So what do you think at this point? So if your patient develop new oxygen requirement post-operatively, we think of possible chest infection, and because she was immobilized, there's a possibility of pulmonary embolism. And so if there's intraoperative oxygen requirement, there's rarely there could be fat embolism, cement embolism when the hemiarthroplasty is inserted. So when we examine her chest, there's right lower zone crepitations, and then we carried out some blood tests. White cell count was raised at 18,000 and CRP was 240. Little bit more than what you would expect uh, immediately after the surgery. And she had a chest X-ray. So what can you see in the chest X-ray? There's some opacity in right side lower zone, mid and lower zones. So suggestive of possible consolidation. So we started antibiotics to treat the chest infection, and we thought this is possibly due to aspiration pneumonia. We got speech and language therapist to assess this patient, and they thought her swallow is not safe. So what would you do at this point? Would you put an NG or would you not put an NG tube? We were not quite sure about the reversibility of dysphagia in this patient. She has possibly moderate to advanced dementia, and the NG tube is not well tolerated by patients. They frequently pull it out and can aggravate delirium. So at this point, we thought we would feed her at risk rather than putting an NG tube. And she was started on antibiotics. On day 5 post-op, now she has received antibiotics for 3 days, and we repeated some blood tests to see whether the inflammatory markers are improving. And she remains agitated despite the infection being treated. She has to have IM haloperidol 0.5 milligram during night for agitation. And repeat bloods revealed white cell count now coming down from 18,000 to 12,000. CRP was coming down from 240 to 90. But sodium was creeping up, which was 148. What do you think is the reason for sodium going up? So at this point, it could be dehydration, possibly to low oral intake. So she had difficulty in swallowing in the first place. The other thing is she's having ongoing mixed delirium, and so she's at risk of reduced oral intake and dehydration. So we thought of better giving some IV fluids to keep her hydrated. So she was given some fluids through the cannula. So challengingly, she was taking the cannulas out. She didn't like the cannulas and she was a bit agitated, so she kept on pulling them out. And we thought of starting a small dose of haloperidol for a short duration to calm her down. And we thought that that might help with her hydration at this point. 2 days after, day 7 post-operatively, now the skin is bruised. And patient is still agitated intermittently, especially at night. At this point, we thought not to attempt further cannulation. So seems like it's traumatizing the patient, and it doesn't seem like a good option for hydration at the moment because she's kept on taking them out. And when bloods were repeated, sodium was creeping up slightly more. So sodium is now 150. So there are indicators of dehydration still. And we started hydration through subcut fluids. And the subcut cannula was inserted intrascapular area in the patient's back. This is been done because patient is unable to reach the intrascapular area, so there's less chance of pulling the cannula out. But she pulled it out the same day, but it was reinserted, and we were able to give some fluids through the subcut cannula. And on day 10 post-operatively, she still appears to be in distress. And her left side parotid area was found to be swollen, warm, and erythematous. So slightly similar to this one. So the parotid area was swollen, erythematous, and it was tender and warm. So a likely diagnosis of acute parotitis was made. Talking about acute suppurative parotitis, this is common in extremes of age. Usually, it's either children or elderly who are more prone for acute parotitis. And the risk factors for acute parotitis are in elderly, dehydration, dry mouth, and drugs with high anticholinergic burden, immunosuppression, silolithiasis, and especially after abdominal surgery, it seems like parotitis is slightly more common. And it's believed like when patient is dehydrated, when the saliva is thickened, there's a chance of retrograde infection. So even though acute suppurative parotitis itself is not a life-threatening problem, when it happens in a background of a patient being delirious, dehydrated, and in extreme elderly, this could be a harbinger of death. So in a small case series, it has been shown that 50% of patients with acute suppurative parotitis, when it occurs, especially in a setting where patient is dehydrated or having cancer, so 50% of patients would die within 3 to 5 days. So ultrasound of parotid can be done to especially to exclude obstruction due to silolithiasis, which we did. And the ultrasound of left parotid gland confirmed the diagnosis of acute suppurative parotitis, and it excluded obstruction. And the inflammatory markers was rising at this point, and the sodium and urea was also rising at this point. It's an extremely painful condition, so we treated with antibiotics and analgesics with a good response. And at this point, we discussed with patient's son regarding the future goals of care. I will summarize the timeline of events after patient's admission. So, as we discussed, on day 1, patient was admitted with a hip fracture, and at this point, the AMTS was 1 out of 10. She underwent surgery, left hip hemiarthroplasty on day 2, and post-op day 1, she was more confused, bit agitated, and AMTS at this point was 0. On day 2, she developed chest infection, likely aspiration pneumonia, and we started on antibiotics. And on day 5, the inflammatory markers were coming down, but because of dehydration, the sodium and blood urea was going up. And post-op day 7, the attempts to IV hydration failed, and we started the patient on subcut fluids. And post-op day 10, she developed acute parotitis, and there was ongoing delirium. Going through her events during last few months, so 3 months ago, she had a chest infection in May, and she admitted to medical ward, treated and discharged, but her functional baseline went down from her baseline, which never came back to her normal level, but she had some form of recovery. And then she developed another chest infection in August. Possibly these infections could be aspiration pneumonia. And then she had a recovery, but not back to her baseline. And then in September, the recent admission, she had a fall and hip fracture, and seems like she's nearing her death. So this is the usual expected trajectory of decline in older people with frailty at the end of life. So at this point, we discuss with the family and we prioritize dignity and comfort. So decided against IV or subcut cannulas for for hydration at this point. supported her with oral fluids and feeds as tolerated. And in case of future aspiration pneumonia, thought of not giving further antibiotics because it might not add days, not add any comfort to her life. And discuss about avoiding readmissions after discharge. And we refer to the hospital palliative care team for further inputs. And it appeared like she had days to weeks left. And then we discharged this patient to a nursing home for end-of-life care and referred to the community palliative care team to come and support her at the nursing home. And after discharge, she died after 1 week of discharge. Thank you very much for your patient listening. And Professor Duncan Fawcett will comment on my case after the presentation. Thank you.
Thank you, Sitara, doing that presentation of the case discussion. So I'll again invite Professor Duncan Forsyth to give his comments.
Great. So that also was a good and raises a lot of issues. So I'm actually my trajectory is going to be through the case rather than start at the end and work backwards as I did with the last case. So the problem with someone who has been confused before their admission into hospital is, are they more confused now than they were before? And the single question in delirium or in dementia is a very easy question to ask. If you've got someone to ask it of, which is this person more confused than usual? And if there is no one to give you a corroborative history, then just assume that they are more confused than usual, i.e. assume they have delirium and manage accordingly, because the management of delirium, the management to try and prevent delirium are the same, and they simply are good basic care. So there's nothing to be lost by assuming that this person has delirium on top of what was obviously a dementia. That was clearly why the son had moved in from that history. So that would be my first point. The second point is I'm always suspicious of swallow assessments in confused older people, because they're extremely difficult to do, and almost invariably the confused older person will fail a swallow assessment. And that may just simply be because they didn't understand the instructions, they weren't able to follow through it. And a speech and language therapist is obliged under such circumstances to recommend nil by mouth. But as in this case, that doesn't actually mean that you have to go with nil by mouth, because confused older people are notorious for not liking you sticking things into them. And so if you did go for an NG tube, they almost certainly will pull it out. But it does mean that you've then got to think very carefully about how you're going to ensure that this individual will get adequate oral intake. And so I would involve the family or a carer if they can be present. Make sure that the nursing staff are very keenly observing whether the individual is drinking. If they're hypoactive delirious, then they may have apathy, lack of incentive to drink, and need someone to encourage them to drink. And if they are hyperactive delirious, they may be suspicious, paranoid about what it is that you're giving them. So you may need to have what is described in the UK as bay nursing. So if you have on your ward a bay with 6 beds in it, having specific nursing staff allocated to that bay so they can keep a close eye on the patients within the bay, see if they're drinking, encourage them if they're not, and alert the doctors if that's not working for the early use of subcutaneous rather than intravenous fluids, because again, with confused individuals, subcutaneous fluids are often better tolerated than intravenous fluids. You can use the interscapular area, and the idea behind that, as the presenter said, is that you can't reach it. The trouble is, it's very irritating because you're lying on it all the time. So you're going to try hard. You can use the abdominal wall, and there you can hide the needle and the tube underneath the nightdress, the bedclothes, and the individual may not pull it out. They may pull it out. The haloperidol, I would question why it was given at night. Was the individual truly a danger to themselves or others, or was it merely to keep the ward quiet? And so forgive me if at this point I raise the spectre of elder abuse within hospitals by hospital staff, because there have been several quite notorious cases recently within Britain and in our media, the most recent being of nurses on a stroke ward deliberately giving the patients sedation so that they could have a quiet time at night. The nurses could have a quiet time at night. And I'm going to stick on that theme for a moment. The bruising, was that simply a result of the needles being put into the individual? Or do check that there are not fingerprint marks and it's not a sign of unnecessary or unnecessarily vigorous restraint by the nursing staff. So apologies to me for suggesting that staff may be abusive, but we know that that happens, and you should always consider it. The next thing is, when do you know, or when do you accept that the war is lost? When each battle seems winnable. So delirium is potentially winnable. The pain of a fractured neck of femur is winnable. Dehydration is potentially winnable. The parotitis is potentially winnable. The almost certain malnutrition that was coming as well, because this person was not taking much orally, is potentially winnable. When do you realize that whilst they're all potentially winnable, actually ultimately the battle is going to be lost? And the slide of the stepwise decline is an excellent graphic. It's an excellent graphic to draw for the relatives in those discussions about end of life, because it will help them see that this is a decline to the grave. And will help them through this very difficult time. So I would encourage you to draw things out, because visual representation is very powerful in helping people to understand what are complex events and decisions. And then I'm not sure in Sri Lanka, but in the UK, death within 30 days of an operation would require referral to the coronial system. If this woman had died within the hospital, there would have been a review, mandatory review of her records by an independent clinician, the medical examiner, which is a specific post now within all NHS hospitals, to review the care of that individual and to see if there are any lessons that can be learnt. I'm not at all critical of what was done with that case, but you can see that when you look at it, if you just look at the end of that patient's journey through the hospital, you could be forgiven for saying that each decline step to that end was foreseeable and potentially preventable. And if that crosses your mind, it's perfectly reasonable to have an independent individual reviewing it and saying, no, actually, Duncan, you're quite right to think that maybe that might not have happened, but actually, if you'll pardon the phrase, SHI1T does happen. And the natural trajectory of this woman over the last 5 years shows you that that was going to happen. You can go to bed, sleep well, and rest assured that you did everything appropriate and that I would have no particular concerns with the care that was given. So that would be my, again, pearls of wisdom. I think a good case showing the trajectory towards the end of life of somebody with a chronic progressive neurodegenerative disease and multiple comorbidity. And remember, draw that graphic out to help the family come to accept that actually end is approaching, it's very close, and supporting the individual, supporting the family through that end of life becomes paramount in what you do. Thank you.
Thank you very much, Duncan. And this concludes the today's specialty update. I would like to invite Dr. Duminda Munidasa, President CCP, to hand over the certificates of appreciation. First, Dr. Varshadi Soisa. Next, Dr. Gaur Shankar. Yes. And we will send the certificates to the Joe Davis and the Sichira Senaviratna. And thank you very much for your kind participation. Thank you very much.